So estimated time lost, these people are typically likely that they are alive. Goal of rehab is return to ADL. Find something less traumatic than skiing like ping pong. And hope they enjoy it. So dislocation from transverse ligament. That transverse ligament is really kind of what pins that odontoid process in place, the alar ligament. If you shift that on top, that C1 on top of C2, and it's able to shift that ring forward or shift C2 and the rest of the spinal column posteriorly, then we're actually looking at that pinching the odontoid into the spinal canal. So you'll have some pretty significant, pretty sudden nerve trauma. We can also have a C2 fraction. There's three primary types: odontoid, Hangman's, and miscellaneous fraction of the vertebral body. So odontoid, that little protrusion we can certainly clip off in different locations. And then the different typings are based on where exactly. And that's not going to mean a whole lot to us so much as it's going to mean something to the surgeons who are putting these people back together. Hangman's fracture is a traumatic spondylolisthesis of axis. So we're actually suddenly shifting and dislocating C2. It's a low velocity, rarely results in neurologic deficit. At high velocity, it severs the cord almost immediately. So it's suddenly grabbing C2 and slamming it forward, which breaks the spinal cord. You're effectively cracking it right across here and here, which dislocates. So we talked about what spondy is a little bit. We'll get to that more in lumbar spine. But again, you have your superior articular facet and your inferior articular facet. And spondy is really when we're displacing or having a stress fracture in between the two locations, that pars interarticularis. And so this is suddenly cracking those bilaterally, which shifts this and it severs the spinal cord. So you can see that fracture site right through there on the X-ray. So cervical hyperextension, possible neurologic, cardiac, and respiratory deficits. Cervical spasm and guarding may be present. Motion may be guarded. Motion will probably be guarded if they're still conscious to guard. Pain with rotational movements of the cervical spine. Trunk rotation replaces cervical rotation. Range of motion should not be evaluated. So if you suspect these, you can do light palpation to assess for tenderness, but you're really not, you don't want to shift and feel and move things around. So what happens if this person gets hit, is on the ground, and their head's turned an awkward way to give CPR? Do we reposition the neck to try to get an open airway? This is one of those very tricky calls, so what do you think you should do? You've got somebody lying awkwardly on the ground, they fell from a height, you suspect a cervical spine injury, you can't quite get to their airway, and you know that they aren't breathing and have no heartbeat. So what do you want to do?
Life over limb.
What's that?
Life over limb.
Life over limb. I mean, in all reality, if their heart's not beating and they don't have, if they're not breathing, they're dead. Unless we can do something to assist or prolong or get them to higher advanced medical care to get them back. So paralysis doesn't trump the fact that you have to have the heart breathing. So you need to get them to a position that you can do CPR. Now within that, you need to stabilize as best possible. So do your due diligence to try to stabilize and move to get that open airway. Now you're not going to do head tilting with the C-spine. You're going to do modified jaw thrust where you're pulling the jaw forward. So you do what you can within what you know to stabilize the neck, but your primary focus has got to be your ABCs, airway, breathing, circulation. Eval pain at cervical spine just below occiput, possible neurologic, cardiac, and respiratory deficits, Hangman fractures are going to be bad days. So X-ray will begin, but CT with sagittal and coronal reconstruction will give definitive. And management. I don't really have a breakdown of the difference between type 1, 2, and 3 outside of the management here. So type 1 is typically puts you in a rigid collar, type 2 is 8 to 12 weeks in a halo.